just we're 2 minutes past 10.
Thank you, Chair. The recording has now started.
Okay, thank you very much indeed. And first of all, can I welcome everyone to the meeting of the Integrated Joint Board for Health and Social Care. Thank you all very much for attending. We have got everyone present. I think that we need to proceed, and what I will do is just to remind folks that the public section of the meeting will be recorded and published online for public viewing following this meeting. Can members activate their cameras where possible to enable you to join by video? And can everyone please remember to mute their microphones when not speaking? Please don't come in during items unless you have indicated and are invited to do so. And I would just like confirmation that everyone has been able to access the papers and indeed the supplementary paper that was circulated by email. And I will take silence as a positive in this case. Please indicate in the conversation pane if you haven't. Okay, thank you very much. If you wish to speak on any point as we go through the agenda, could you please just put a comment or a question or just a Q or a C in the conversation pane, and I will take people in order of notification. And if you've dialed into the meeting and you don't have that available, please just say your name and I'll take you also. So I'll bring you in at the appropriate time. If any members lose connection or have any technical issues during the meeting, please alert Jan, the committee officer, by a separate Skype instant message if possible, but support will be available from Gordon from ICT during the meeting if required. So with that, we will proceed to the business. I'll ask Jan if we can go through the sediment, please.
Thank you, Chair. We'll do the sediment in two parts, the first voting members and the second non-voting members. Councillor Sterling.
Present.
Mrs Atkinson.
Present.
Ms Anderson.
Present.
Mrs Duncan.
Mrs Duncan.
Present.
Councillor Robertson.
Present.
Mrs Little.
Present, Jan.
Councillor Reynolds.
Present.
Councillor Robertson.
And good morning.
Councillor Ross.
I'm here.
Mrs Webb. Susan Webb? No, I don't think so. Come back later perhaps. And in terms of non-voting members, we have apologies from Dr Allen. Dr Brown, June Brown. Fiona Culbert. David Heckler.
Present.
We have apologies from Sue Kinsey. Mrs Kirk.
I'm here.
Martin Mackay. No. We have apologies from Dr Metcalf. Mr Mitchell. George Mitchell. No. And Mrs Angie Much will be a wee bit late. We have apologies from Mr Ramsey, Mr Sharp.
Present.
And Mrs Wood.
Present.
Chair, that's the sediment, and we'll keep an eye on any latecomers. Thank you.
Hi, it's Martin Mackay. Did you hear me?
Oh, yes,
no,
Martin.
thank you.
And Lizzie Finlayson. One of Deputy Clinical Leads. Yeah.
Dr Finlayson, yeah, you're welcome.
Julie, and I'm one of the Deputy Clinical Leads.
Welcome, Stuart. Okay, we have everybody else.
Kathy
And I
Davidson here. Oh,
hi.
Hi, MyCog. Apologies, please, Jan.
Okay, that's fine. Thank you very much indeed. Do members have any declarations of interests, please? I see none indicated. Can we move then to the statement of equalities? And can I ask members that they agree to take due account of the duties that are included in your pack? And I would ask you to indicate if you do not agree, please. Otherwise, I will take that as an acceptance. Okay, thank you very much. It's my intention today to take item 12 as an exempt paper. Can we agree?
Agreed.
Okay, thank you very much. And we'll move then to item 3 on our agenda, which includes the minutes of the meetings of the Integrated Joint Board on the 26th of February and the 25th of March. And those start on page 5 of your pack. Can we first, in the first instance, agree that those minutes are an accurate record of the meeting?
Agreed.
Agreed.
Thank you very much. Thank you. And can we go through on page 5 and if members indicate if there's any issues they wish to raise? And as a matter arising on page 5, 6, 7, 8, 9, 10, 11, 12, 13. And on the 25th of March, page 14, 15, 16, 17, 18, 19. Okay, thank you very much. We can agree then that those are accurate records of the meetings. Thank you very much indeed for that. Item 4 on our agenda is the statement of outstanding business, and as always you will see there the items that require further attention from the board as we go through, and indeed those which have been completed since our last meeting. I will just take any questions or comments from members should you have any on the items in the paper. No questions? Okay, we'll note that then. Thank you very much. That takes us then to item 5 on the agenda, which is the Chief Officer's update. And can I hand over to Mrs. Wood, please, to take us through this?
Absolutely, thank you, Chair. I'll just pop my video on. Good morning everyone. It seems a very long time since our last formal meeting, and I think particularly when we reflect how much has changed since that time at the end of March. So we were just beginning our lockdown at that point, and I think we are now starting to see some of those restrictions easing, and I'm not really sure that I was able to think about June time when we last had our meeting in March. So as you'll see from my report today, our COVID response continues with plans to make sure that those who are shielded and vulnerable are still able to access the health and social care they require. You must remember we will need to comply with all of the social distancing measures, and obviously there was the announcement yesterday from the UK government, but I would imagine even as we see some of those social distancing restrictions ease, we will still have a responsibility to protect the vulnerable, and I think it was interesting just to note some of the comments that were made around the 2 metres or the 1 metres, and actually for those who are vulnerable, I think that 2 metre social distancing measure will still continue to apply. So although perhaps we will see some easing within some context, I think it will be really important that we continue to think about how we protect those vulnerable people within their communities. I've also made comment in the report about our staff. I'm clear that the effectiveness of our response has been entirely down to our staff and our integrated teams throughout the last few weeks. At no time have I felt we faced a challenge that our teams have not risen to, and I would particularly like to draw attention to the contribution of the Live Life Aberdeenshire staff within our response. They've worked alongside us in our care homes, and have been particularly key around some of our distribution processes around PPE. I'd also like to just draw some attention to the work our commissioning team have been doing throughout this response. I think sometimes we focus very much on our frontline staff, which is absolutely essential, but some of our staff, particularly in our commissioning team, have worked really tirelessly to reach out to our providers, to work alongside them, thinking about how we can best support them to in turn support the service users that they support. Our care home oversight group, and I know I've discussed that a number of times within the informal catch-ups, that has pulled on members from right across our own team and the wider sector to be able to support those services. As mentioned in my report, I do want to raise comment around some of the positive things that we've done over the last few weeks. And again, you've heard me speak about these before at the informal sessions, but really our use of technology over the last few weeks and months has been really key. So you'll see in the report that the first week of March we were using probably around 11 near me appointments, and actually that has now risen to over 450 per week. So that is a massive change over such a short period of time. And behind each one of those 450 appointments is an interaction that's been allowed to happen using that technology that potentially couldn't have happened within the lockdown measures. So I think that's so key and so important to thinking about how we move forward. The other ways that we've used technology, again you'll see that within the report, we received a very generous donation, and that has meant that at scale and at pace we could increase the amount of technology that we have within some of our care homes, within our very sheltered housing, and we've used that technology to make sure that people can stay connected to their families even if they don't have access to that technology itself. In my final paragraph of my report, Chair, however, I thought it was important that we acknowledge that all of the challenges that we faced going into pre-COVID and into the COVID period are still there. We know that our challenges of resource and demand have not gone away. And I suppose a question now that I'm hearing maybe at a national level is that question about, are we less resilient now than we were going into COVID? And how does that prepare us for thinking about the future, thinking about the winter, thinking about potentially a second phase? So happy to take any questions on the COVID report, Chair. There are another couple of items within my report itself, an update for the board around the HMP Grampian Healthcare Improvement Plan. The board will be aware of a number of different documents that have come to the board over the coming years, over the previous years. We do intend to take that improvement plan. It's already gone through some of the governance groups, but we're keen that it goes through the governance committee and then come to the IJB as appropriate. Following that visit in October, the main issue for us was around the controlled drug licence. So that application has now been submitted, but unfortunately COVID has drawn a halt to that being taken forward by the Home Office, but hopefully that will be one of the first things that gets reinstated once we can start that process again. There's comment about the use of delegated powers, which again we'll come to when we cover item 12 in the agenda. And finally, just a couple of staffing updates that I just wanted to bring to the board's attention, mainly due to the board will recall that I'm in the interim post for a one-year period, and that Geraldine is in an interim post around her partnership manager in Central. So there has been a decision made with through the chair and the vice chair that those secondments will be extended for a further 6 months to allow us to get through this period and follow on with appropriate recruitment processes when the times come. So I'll maybe stop there, Chair, but obviously happy to take any questions from the board.
Thank you very much indeed for that, Angie. And just to add on to what you've just said, fortunately, Angie and Geraldine have accepted the invitation to extend their secondment. So just to round that off, so we're very, very grateful to you both for that and look forward to working with you further in the future. So thank you for that. I have questions from Amy Anderson, Councillor Anne Ross and Joyce Duncan in that order, please.
Me next on your list, Chair.
Certainly, Dennis.
Thank you, Chair. Can you hear me okay?
Yes.
Excellent. Okay. I'd like to thank Angie and her team for the monumental effort that's gone on in the last few months. It was really good reading the update and getting a kind of summary of that, but to really kind of recognise the enormous amount of work that's gone on over the last 3 months. So to kind of formally thank you for that. I think the innovations developments on the use of technology and the partnership working with stakeholders like the police and NHS and others, and particularly third sector and community bodies as well, has been amazing. And I'd like to formally pay tribute to those charities and community organisations who've all done an equally amazing job. And I've actually been working on the humanitarian hub, so I've seen that for myself, and that's been really a real privilege to be part of. I guess something that came up for me in my work on the hub was the issues around things like accessing podiatry for people who were shielding. I know there were particular issues with that, so I just wanted to kind of ask, have we learned any lessons from that? Should we have a second wave, and should shielding people have to do so for any length of time? Thank you.
Chair, if you're happy for me to pick that up,
Yes,
I may ask clinical colleagues to come in if that would be appropriate, if I say anything wrong clinically. I think absolutely, Amy, you know, we've got so much to learn around this situation. You know, I think the lockdown was very severe, and I think was absolutely required in the circumstances we found ourselves in. But you know, we have undoubtedly learnt lessons around that. I think, you know, I'm sure we could communicate things better, and I think ensuring that people are aware of the escalation routes that are available should they require that urgent help. I think there is something about how we've communicated the concurrent risks around some of this, Amy, if I'm being honest. So, you know, I've certainly reflected not around podiatry, but a number of other issues that maybe people have raised as a concern because they're not getting the exact treatment they did in the past, and I think it's about how do we have that conversation around well, what are the risks actually involved here. So actually an interruption in a certain form of treatment may actually pose less of a risk than it did when than the risk of COVID did, particularly through different phases of the lockdown. So if I had a crystal ball to tell us what the next few months would be like, things would be so much easier, but we know we don't. And I think a conversation I had with the clinical leads this morning around particularly that shielded group, particularly some of these protected places that we may need to, protected clinics that we may need to set up. For me, it's about how do we give people choices and how do we give people the right information to be able to make those choices. So it may well be that somebody has to choose between slightly more of an inconvenience of a travel to get to one of our protected hubs, whereas they may be able to access that same treatment closer to hand, but we need to think about some of the risks that may be that we may not be able to mitigate against around that not being a protected site. So I think there is something about how we communicate, how we measure and evaluate those risks going forward, and I would hope that's something that we could learn from, will learn from, and potentially have the time to be more sophisticated in our responses than maybe we did when we were plunged into such a kind of brutal lockdown so very, very quickly.
Thank you. Thanks, Angie. Thanks, Chair.
Would any of our clinical colleagues, Stuart or Lizzie, want to add anything to that?
Nothing today. I think Angie's covered it well. I think exactly that point that each clinical interaction had to have a sort of balance of risk versus benefit, and we're still learning about the virus as we go on. And I think exactly what Angie said at the end, then I think as we learn more, our response can be more sophisticated going forward.
Yes, I would agree as well. But I think it's all, I think we're now getting back to a situation where we really have to concentrate on infection control, and that goes across the board for every single patient. And it just reminds us actually that perhaps we've become a bit complacent, I don't know, but we are really, our good infection control has been what's limited this so effectively. So it's a balance of risk, and that risk may include some of the more vulnerable, the shielded patients taking ownership as well, or us all taking ownership for ourselves a bit, in order for a service to resume and some sort of effective service that is sustainable can continue, because you know it's all very well doing lockdown, but it's not a sustainable arrangement really.
Thank you both very much for that. Thank you. Amy, are you happy? with their responses?
Yes, Chair. Thanks very much to everyone.
Okay, thank you very much. I've got Anne Ross next, please.
Good morning, everybody. I hope you're all well and are keeping safe. My question, well, first of all, I would like to say thank you very much to everybody that has been working in the Health and Social Care Partnership and in the NHS for all the hard work. And I know it's been a really stressful situation. I've been hearing from my friends, and I would commend everybody and thank you all from the bottom of my heart for what you've been doing. We've been talking about COVID-19, and in the media today they've been talking about perhaps letters about perhaps another outbreak in the winter. With the fight against COVID-19, I think Dr. Finlayson is absolutely right that hygiene and infection control is one of our best ways of beating the virus, but also so is testing. That's one of the key tools that we have in our armoury. Can I ask how the testing in care homes is progressing, and also how many people we've tested, and how often testing is going to be repeated in care homes of patients and staff? Thank you.
Chair, I'm happy to pick up on that. I might ask Stuart to come in after I've said my piece, because Stuart, as part of the oversight group, may have particular insights into the testing. I think it's just really, I need to be very clear that obviously we have an obligation to our residents to ensure that they are tested and have access to testing, but that testing is delivered by NHS Grampian and in collaboration with various national models that are now emerging around testing. So happy to discuss what we have seen on the ground, but I think it's I just need to be really clear that we are not responsible for delivering testing. I think within NHS Grampian there has always been an acknowledgement that testing is an incredibly important part of our response, both in terms of the evidence around testing, but actually in that collaborative whole system approach that we've adopted. So testing within care homes probably started within Grampian earlier than it happened elsewhere. It was very much supported by the Health and Social Care Partnership and by our local GPs, who enabled us to be rewriting tables and flowcharts probably on a daily basis for a wee while, until we got the right testing around the care homes. So we have a fairly standard approach to all testing now. Anybody with any types of symptoms is tested. If we feel that there is evidence of COVID within any area, there is blanket testing of staff and residents within care homes, and there's also a rolling programme that looks at testing care homes on a regular basis to ensure that we're not missing any infections. Obviously, I think the big learning for all of us has been around that asymptomatic presentations of COVID. So that is ongoing, and I think we are now in week 2 or week 3 of that rolling programme of testing, but I would reinforce that I think where we have required testing to be done in that collaborative and partnership model that we have across Grampian, we have been able to get that testing accessed. Stuart, I don't know whether you would maybe want to come in with any comments from the oversight group's perspective around that.
Yeah, I mean, just to say, obviously well, first of all, to acknowledge we do have an exceptionally effective oversight group that's also looking at all issues to do with our care homes, and that includes testing, where we've got excellent input from Health Protection Scotland that advises as to how we're getting on with that. My understanding is that it is now available, as Angie Wood says, on a rolling basis. I believe it's a 12-week rolling basis, but I could be corrected on that, but that was certainly the intention. And each resident will be tested, and each member staff will also be offered testing on that basis. So they're testing whole care homes at a time. Over and on top of that, of course, there's also, as Angie said there, the symptomatic testing and the blanket testing when there has been any sort of confirmed outbreaks. So there's a lot of rigour and reassurance that's now going around our care homes, and so we feel very reassured that that's in hand.
Thank you both very much indeed. Sorry, Councillor Ross wanted to come back, and then I'll take you back in, Angie.
Okay, thank you.
Sorry, thank you very much. with the testing, we had at the beginning patients being discharged from the ARI hub, from the centre, out to care homes, not having been tested. Can I ask now for assurance that, and following that, we were assured that everybody was being tested who left ARI, went out to the community hospitals and to the care homes, and likewise when people were going from there into ARI. Can I ask for assurance that that is still the case, please?
It absolutely is the case. I mean, those who are over 70 are tested regularly now within hospital, and people are required to have tested negative on discharge. I would stress, however, that the testing is not 100% effective. So, you know, we do have issues with tests which are not reliable, or reliable probably isn't the right word to use in this context, actually, and I might hand over to Stuart to see if he can give a better description of it. But I think there are issues with the process of testing, and again, you know, this is a test that has been developed over a period of weeks, when often we are relying on testing that, you know, we have refined and developed over years. So I think there is I have a caution around testing. I absolutely see it as part of this process, as part of our resilience and understanding of the illness, as part of our response. But I think it is only part of that response. So I would quote Lizzie Finlayson, who has directed us again that, you know, actually really rigorous, proper infection control measures, us all washing our hands, us all being really careful around surfaces, is as important, if not in some ways more important, than testing. So there can be an issue of an over-reliance on testing, and perhaps even a false sense of security around testing. So I would absolutely stress, let's absolutely get the testing right, but let's make sure that we're being absolutely meticulous around our infection control processes and our own hygiene that we all need to be thinking about in the weeks and months. So again, I might ask Stuart if he had any other comment around the testing itself.
Yeah, and just I suppose to acknowledge that there are both false positive and false negative tests, and there's been a lot of evidence around that. So that's part of the reason that we do serial testing, both before discharge to our care homes and community hospitals from secondary care. Also, within our community hospitals, we're doing serial testing there every 3 or 4 days as well. And yes, to make the point exactly that even if somebody is discharged to a nursing home from secondary care with negative tests, we would still isolate them for a period of time and follow strict infection control procedures. As Dr. Finlayson said earlier, that is our key weapon in this, making sure staff are wearing the correct protective equipment at all times.
Thank you both very much indeed for that, and I think it's good to stress the fact that testing is part of the toolkit. It's not the panacea. So, but again, I think we need to be clear about the message that we send out to the public from this meeting, in terms of all the actions that are being taken and all the precautions that are required are multiple and not just reliant on one aspect. But I do think we need to be clear in terms of our public messaging, what exactly it is that is on offer, if you like, or is available, where it fits with the overall picture, but that infection control message is absolutely clear. So I do think we need to be very careful about the messaging around all of this. But thank you both very much indeed. I have Joyce and then I have Dennis, please.
Thank you, Chair. I was just going to ask, given that the IJB has the overall responsibility for care homes, is it a timing issue, or why are we not getting the same reports as the NHS are getting? Because that would have clarified so many of these questions, because there's some great reporting coming from Susan Webb's team about the oversight group, what's being done, how the testing is being carried out. And I think it should be the IJB that sees that.
Chair, if I could come in there, I mean, I was only aware of that report quite recently, Joyce, so I think it is a kind of early look at some of the data. That does particularly focus around discharges from hospital and for the testing, which, as I say, NHS Grampian is responsible for. But I'd be more than happy to ask Susan if I can share those reports with the wider IJB, if the Chair and Vice Chair feel that's an appropriate route for us to take.
Thanks, Angie. I think it would be appropriate for us to see it, given that it's our responsibility to look after care homes.
Well, can I just interject? In the first instance, has everybody still got connectivity? Because the servers are dipping in and out. So is everybody still okay? In the first instance, that's the first thing.
Chair, I'm okay.
Yes.
Okay,
Yeah.
thank you.
Yes, Chair.
But I think, Joyce, the point that you make is a point that I have been grappling with for some time, and I don't think it's appropriate for us to necessarily just be told in this kind of forum that there is a report circulating. I think Rhona, as Vice Chair and of the IJB, myself and Angie will approach colleagues in NHS Grampian and try and reach a position where we can actually agree to have appropriate information shared at the appropriate time. I'm very uncomfortable, I have to say, with this kind of approach. I think it's a conversation we would need to have, I think, with colleagues in other partner areas. I'm happy to take it off table if that's appropriate with yourself, because I think it's unsettling and a little bit for members who are not on NHS Grampian board, because obviously if there's work going on elsewhere that we are not cited on, then I think that's unfortunate. But I do think it's probably a timing issue, and I think that we'll have that conversation. Rhona and I will take that off table with Angie, and we'll speak with colleagues, and we'll try and get some time frames and some parallel reporting processes in place, so that everybody's cited on the same information at roughly the same time. Obviously, it won't always be ideal, but if we can do that, that would be helpful.
Lovely,
so
thank you very much, Chair.
We'll do that. Thank you, and thank you for raising that. That's helpful. Right, Dennis. Oh, sorry. Hello.
Sorry, it's Susan Webb. I had a bit of difficulty getting on.
Sorry.
So I've just phoned in, and just to say, really happy to have a conversation about providing information. I was aware that the assurance elements of care homes that the Health and Social Care Partnership have pulled together for Aberdeenshire had previously been circulated, but we can look at how we supplement that with the national reporting that we have to do.
I completely understand that you have a pressure nationally, absolutely, and I think it is probably a timing issue, but we have to try and ensure that as a collaborative and as organisations and partners that you're tasked with co-producing, and we do have that working group that I sit on in terms of recovery, etc. I think it's really important that we line up our information and the IJBs are included in circulations at the appropriate time. Obviously, some information is in the ownership of one or another of our partners, but I do think to be able to go forward as a whole system, we need to tie up these things. So that's very helpful, Susan. Thank you. Amy has commented that there are asks of NHS boards that could more appropriately be directed through IJBs and health and social care partnerships, and I do think that's something that we're all grappling with as well, about how we best champion health and social care delivery at a local level, and having the recognition that IJBs are actually the models and the vehicles where these things should be discussed and delivered. So I completely agree, Amy, that there is a disconnect there in some ways, but if we can do anything at any point in our discussions with others to champion that health and social care, that integrated model, because we do have some really, really good examples here in Grampian, then I think we should take that opportunity. So again, thank you for that, Amy. Dennis.
Thank you, Chair. A couple of questions, if I may. One, Angie, in your report, you mentioned the staff from Aberdeenshire, Live Life Aberdeenshire. I know that some of these staff have been deployed to assist. Now, when these staff go back to their normal jobs, how content are you that we have the appropriate staffing levels within our care home system and our obviously other areas of responsibility. And also, given that there's been a great deal of effort, energy put into ensuring people's safety through public health messages, etc., people have maybe been slightly reluctant to take, say, holidays. And I'm just wondering if you're monitoring how staff are in terms of, look, you're tired, you need to take a break, and we've got that appropriate cover. So those are the questions really. And the other one is about, how do we have a message to go out in terms of how we self-manage? Dr. Finlayson was sort of kind of alluding to we take a certain degree of personal control. But in terms of self-management of people's conditions, are we preparing a message to go out to try and embrace that? Because it is something very positive that's come out of, I think, our situation. And it's something I would like to see if we could develop how people take that sort of personal aspect about their own health and well-being. I'll stop there, Chair. Thank you.
Thank you, Dennis. I always like the challenge that you give me of three big questions in one breath. So thank you for that. So yes, the Live Life Aberdeenshire staff, we continue to work really closely with Avril Milne and her team. Avril has been just fantastic through this period. We've absolutely identified the staff who would be both willing and able to come and work with us. Many of those staff are we brought them into the care homes to begin with, and maybe just to help the IJB, just to give a wee bit of the kind of history to this. We felt that the care homes was the safest environment, I suppose would be a way of describing it, that we could bring the team to work with us, to be able to look at their skills. Sorry, it's Avril Nicol, my apologies, I don't know where Milne came from. But how can we identify the skills that staff have already got, and how can we support them through an environment where they would certainly not be left alone? So our idea was they would come in, work in our care homes, and then should we have had the levels of sickness absence that we felt we may have been facing, we could then utilise them in different areas across the team, perhaps to support home care, etc, etc, etc. Obviously that level of absence has thankfully not happened. The numbers, although are tragic for each and every case that we've had within Aberdeenshire, we haven't seen the level of absence that perhaps we had planned for, so I'm very grateful for that. But I think what we've been able to do is to utilise those staff to really enhance the offering that we've given during this time. So many of those Live Life Aberdeenshire staff have drawn on their existing skills and knowledge to be able to help us to really minimise some of that social isolation that people have experienced within care homes. They've been working with some of our staff within our oversight group to put together packages, movement packages, different ways of approaching what they would normally do within a care home, that some of the movement restrictions has stopped us from doing, just to really encourage people not to feel trapped within their own rooms, where possible, to get people out and about, to get people moving in a safe and controlled way. We've utilised some of the online resources that Live Life Aberdeenshire have produced, and again thought about how do we utilise them within some of our care homes, within some of our residential units. So I think they have brought not only physical capacity, but they've brought all their skills with them as well. So I would hope that as we think about what the future looks like, there's a much closer relationship between ourselves and the Live Life Aberdeenshire staff. Those who live in care homes are a significant proportion of our population, so really keen that we continue to use those staff to use those relationships that have been built up and that knowledge interaction between both the Live Life staff and our own staff, so that if Live Life Aberdeenshire staff are then working with maybe a more vulnerable group, they feel they've got skills and confidence that they've developed. Your question was around when they return, so we'll definitely be working closely with our colleagues to manage that return and for us to look at our own staffing requirements as that changes. But in many ways I think this was an addition to what we had, and also some protection against increasing vacancies. With regards to people taking holidays, you've maybe been reading my emails, Dennis, because I actually this week put out an email to all of the staff to say, please take holidays. That may not be your traditional holiday because you're not going away this year, but that doesn't mean that you don't need time away from work. So that is certainly a theme that I think we need to think about. Just because you're not going on your usual 2-week holiday this summer, actually we still all need to take a break and we need to take some downtime. So that's definitely something we've been working on in the last few weeks, and we'll continue to encourage people to be doing that. The message again around self-management, and good that Susan's here, she may have a comment or two around that. I think there is real learning from what has happened over the COVID period. We are starting to kind of tease out some of the data to understand exactly what's happened during this time. So you can't usually have a control group that you just take away a lot of services from. That usually would be viewed as unethical, but that's what we've got at the moment. So how do we learn from that, and how do we help people to maintain that confidence to actually self-care and self-manage, rather than feel, oh, it's okay, we can hand it back over to the professionals now? Because certainly you've heard me speak before around that idea that we absolutely need to empower people to be able to do that. So we're looking at the data, we're trying to understand it, and hopefully there's a message in that data that actually says, you know, people's outcomes are as good, if not better, where they self-care and where they self-manage, rather than necessarily always rely on that kind of professional support. I'll stop and draw breath there, Chair.
I've got Dr. Finlayson and then Dr. Reary, please.
Yeah, it's really just on the last 2 points. Maybe I agree absolutely. Getting people to have a break, because everybody says, oh, those who've been not working or furloughed or whatever, it's been one thing, but those who've been working on the front line, it's really difficult, even if you have time off, because they can't really get away. And I think this is, for me, an area of concern going forward, that we're going to have quite an exhausted workforce potentially, and who you hope can recover over the summer, perhaps in time for another surge if we're going to have it. We don't know. So I think it's something we have to remain very aware of. The other thing is, to me, there's a difference between ownership and self-management. I think ownership is the responsibility to safeguard yourself and also to safeguard others from yourself in a way. So that's one thing. And self-management, I think this is the ideal opportunity. We've struggled to get this through to people, and suddenly here we have something where people actually don't want to see us, if they don't have to. And I think it's a brilliant chance, and it is just what we've been needing to encourage people to take responsibility, because quite honestly, a lot of the stuff GPs have been doing on chronic disease management, they don't actually need to see you, they don't need to be there. You can put it to people, and I think when they are responsible, they manage it better because it's themselves rather than us telling them. So I see this as a great opportunity, hopefully. Ever the optimist.
Well, absolutely, absolutely. We welcome that approach. Dr. Reary.
Yes, again, just picking up on Councillor Robertson's self-management point, I think Dr. Finlayson's absolutely correct. It's a wonderful opportunity we have here. It's been a really positive learning curve. From the point of view of tools that are out there, I mean, NHS Inform has become a website that people have got very used to using during COVID, giving a lot of advice about how to self-manage their conditions. And the information on that site goes far beyond COVID-19. It gives self-management advice about the whole gamut of medical conditions. Locally in NHS Grampian, we've also got a website, Know Who to Turn To, again, that gives lots of this information. practices have moved towards total triage system, meaning that every contact is triaged, and that's been as a requirement to reduce footfall to practices. But again, that gives us a great opportunity to encourage self-management as well, where appropriate. So I think Councillor Robertson's right. The public message going out about this and advertising, if you like, these sites is going to be key and important going forward.
Dennis, did you want to come back?
Yes, Chair, and I'm very grateful to everyone for their comprehensive answers. The only thing that I think still, it's not a concern, but what I'm not really hearing, although Dr. Reedy Stewart just mentioned it there, how do we develop the communication? How do we get the message out? How do we ensure that we can take the positives and embrace it moving forward? So what I'm hoping to hear is how we develop that communication. How do we continue that level of communication? Because I think it's really, really important, and I couldn't agree more with Dr. Finlayson. You know, this is a fantastic opportunity we have to embrace something that we've maybe been trying to achieve for many, many, many years. So it really is that communication message, Chair. Thank you.
Thank you very much, Dennis. And when Dr. Reedy was speaking, oh, sorry, who's this?
It's Susan. Sorry, I wasn't quite sure how to, because I'm on the phone.
Yeah, can I take you in? I'll take you in shortly, Susan. I've got Angie and then yourself.
Yep.
Okay, you're right enough. Just shout out, because that's absolutely how we can know that you're wanting to speak. But when you were speaking, when Dr. Reedy was speaking, it was in my mind to suggest that actually we asked Jo to work with our clinical leads and Angie and her team to work up maybe a few feature articles, or to actually try and get this message communicated appropriately, Dennis, alongside some of our partners. So that was certainly an ask I was going to have at the end of this, is to actually ask Jo to work with our colleagues to actually start to put those messages out on the behalf of IJB in the first instance, but in collaboration with others. So, but Angie, you wanted to come back?
Yeah, I just wondered if it might be helpful to ask Jo to maybe just describe some of the work that we're doing under the Home First banner, because although Home First might be viewed as its main priority about trying to avoid admissions, I don't really think it is, and I think it is all about that self-management message, and how we utilise all of our resources to manage things well. So I don't know whether, Chair, you would want Jo just to give a few comments on that work just now, or happy to prepare a briefing for later if that would be more helpful.
Well, I'm happy to invite Jo to say a few words, but I think there's probably a briefing in this, and with some steps going forward on an ongoing basis, actually, because I think that the opportunity is there, so we should try and capture that in terms of public messaging. But Jo, if you'd like to say a few words, I am conscious of time because some of our colleagues have to be elsewhere. So, Jo.
Hello everyone. So we're working on the comms plan for Operation Home First just now, pulling the materials together, and there's certainly briefings in there for everyone, and also public communications around it as well. The strapline that I've kind of attached to Home First is less about the sort of nuts and bolts and the how we do it, but the strapline is working together to stay well at home, and a huge part of that is self-management and looking after yourself as well. So it pulls in all those kind of messaging as well, that it's not just about how we deliver services, it's about how we work across everyone, including communities and individuals, to stay well and stay safe at home.
Okay, thank you very much. And Councillor Ross has put up a question about patients and people. So how do communities feed into the process of self-management, etc., going forward? And where practices of patient participation groups, how are they involved in those discussions? So again, maybe that's something that we can ask folks to take off table and bring back a full briefing on how we go forward. Can we agree that?
Agreed.
Okay, thank you very much. Does anyone else have any questions for Angie on the Chief Officer's report?
It's Susan. I just had
Sorry,
a
Susan.
comment on the last
Susan. Yes, sorry, Susan. My apologies. Can you come?
No, not at all. I guess just a couple of points on that last point about engagement of the public and third sector colleagues. The supported Self-Management Alliance in Grampian was very active before COVID-19, and discussions had started about reinvigorating that, because it is an excellent way about getting direct feedback from our population about what we can do to support them to self-manage. I think the other point I would make, we talked quite a bit about individual responsibility. I guess we do know from some of the feedback that the biggest barrier is professionals and our hesitancy to co-produce, work together with patients on their care. So supported self-management is part of the remobilisation plan, and as others have said, it's a fantastic opportunity for us to ensure that our plans enable our patients to self-manage where they are able to do so.
Thank you very much, Susan, and apologies again. But clearly public health would be one of the main partners in taking this whole communication project forward. So we'd very much welcome your input, Susan, with not just from yourself but from your local teams as well, so and Kim. So thank you very much indeed for that. So with that then, we will get a briefing at the appropriate time in terms of a communications plan. We'll work together with our clinical leads across the Health and Social Care Partnership, with public health and with other appropriate partners, and to bring forward some clear messaging around self-management and try and take that opportunity at wherever we can to actually capture what has been happening and give general practice and primary care the opportunity to perhaps look at the activities that they are responsible for and actually have to take forward in very different ways now. So with that, can we move then to item 6, please? And before we do that, can I just thank Dr. Finlayson, Dr. Reary and Ali McGruther, who have joined us to discuss the papers to date, and I know that they have other callings on their time today, so if you have to go before I get a chance to thank you very much indeed, I'll take this opportunity, because without the clinical leadership across health and social care, then I think again we'd be in a very different place. So your clinical leadership has been remarkable and very much appreciated. So thank you, and to your colleagues for everything that you've done and will do as we go forward in this new environment that we all are grappling with to get to grips with. So thank you very much indeed, and please pass on our thanks to your colleagues. Thanks very much. Item 6, colleagues, is the Audit Committee report to the Integration Joint Board, and we have a report before us, and what I would like to do is to ask Amy, as Chair of the Audit Committee, if you would like to speak to that in the first instance. Amy?
Thank you, Chair. Thanks very much. I think the report is hopefully fairly self-explanatory, so happy to take questions with the help of Alan, please.
Colleagues, Councillor Reynolds, you have a question?
Thank you very much, Chair, and thank you, Amy, for the report. I wonder if you can help me understand whether to use the opportunity hook that's been mentioned by Drs. Finlayson and Reary in relation to best value and the development of that and the review of it that's contained within your report. Is there an opportunity here? Is there guidance, or is there scope to look at how we do best value in the COVID context? how we evaluate it, not least in relation to community impact. I mean, we're told obviously that as has been mentioned, we have opportunities to do things differently, and I'm just testing the water, which might well have been well trodden on. If so, my apologies. But in terms of best value, is there an opportunity here that we can visit that concept so that we do things differently in relation to that? Thank you.
Thank you, Councillor. It's a really good question, and best value is something I'm certainly really interested in as chair of the IJB Audit Committee, and I know that we're having ongoing discussions with that, and I know Angie is very keen to have that. I wonder whether Angie and Alan, you want to come in and give a bit of detail on your thoughts.
Angie?
I'm more than happy to do that. So I think if I can remember, again, it's pre-COVID, so it does become a little bit hazy. But certainly at the last audit committee, I think we had quite a robust discussion around best value, and my understanding of it. And I will admit I'm relatively new to the world of best value in the way that the local authorities have made really good use of it in the last few years. I think it does give us a different lens to look on things. So certainly that discussion at the last audit committee was how can we use that to inform our system about the decisions it's making and the impact of that. I probably hadn't really given enough time, Councillor Reynolds, to thinking about what COVID then feeds into that, but I think it's a really good point, really well made, and I think something that we would be interested to maybe hear from other audit committees how they are going to approach this, and I think definitely something that we can look at through our audit committee, because I think for me best value just has that really, I think maybe in some ways a unique mechanism of taking that multifactorial view of the world, rather than maybe just looking at it from clinical outcomes or financial outcomes or individual outcomes. It actually has a really good way of bringing all of that together to give us a much more holistic assessment. So I think it's definitely something we should look to do. I don't have a clear plan in my head of exactly how we would do that at the moment, but more than happy to take that off table, and also talk to our auditors around that and get some advices from them as to how we could approach this in maybe a different way.
Thanks, Angie. Alan, is there anything else you'd like to add?
Sorry, Amy, Alan has indicated that he'd like to speak.
Yeah, thank you, Chair, and thank you, Councillor Reynolds. It's a very good question. As Angie said, the guidance was developed by Audit Scotland pre-COVID, and it was how they could spread the best value programme, which they use in councils, to health and social care partnerships. But I think, as we've just heard from our clinical colleagues, the advent of COVID gives us much wider opportunities to take forward the best value agenda than perhaps we had before. And so I would expect our Audit Scotland colleagues to be coming back and giving us some more guidance on that in due course. But it's something that the Audit Committee will be focused on.
Thank you very much indeed. And I think as we'll hear later in the agenda from Mark Simpson, who's been working on the resetting, rebuilding, recovery piece in terms of the IJB. I think when we get to a position where we can consider that, then I think the next thing we should do from that is actually have an informal session of the IJB and invite an external auditor back. Anne MacDonald joined us previously to talk about best value, and I think with the new environment that we have, then it would be an opportune moment for the IJB collectively to have that session with Anne MacDonald when we have recast the environment that we work in, and I think that would be helpful for us all actually. So I think that would be a really good starting point for the board, and then the audit committee obviously have a clear responsibility and interest in taking that forward, and we must put the best value in context with continuous improvement, which would fit with Mark's work. So Rhona, I have you.
Thank you very much, Chair. Two comments to start with. I'm greatly pleased to see that you're following up on outstanding recommendations. As a
considerable experience of audit committees, that is something that is very useful to do. So I'm pleased to see that that's happening. I'm also pleased to see that in the audit plans for next year, we're going to look at hosted services. I think when we get to the finance questions of this year and next, hosted services will feature. So having another set of eyes on that will be extremely useful. Where I'm looking for reassurance is where officers have undertaken to issue guidance on the importance of following procedures and accurate record keeping. Don't want any detail because that's not the job here, but my assurance that I'm looking for is it of anything of high level importance, or is it a more regular day-to-day maintaining of records that the situation came from? Thank you.
Amy and/or Alan?
Yeah, thank you, Chair. I can answer that one. Yeah, that point came from the internal audit review on the use of purchase cards, which are cards used in social care services to make small purchases. So there were a number of minor recommendations about the record keeping at local offices. So they were fairly low level.
Lovely, thank you.
Okay, thank you. I don't see any other indications. Pleased to see that Angie Much has joined us in the meeting. But the recommendations in this paper is to we're being asked to note the following key points and assurances from the committee in relation to audit matters. Are the board assured, and do you agree with the recommendation?
Yes.
Yes.
Agreed. Yeah.
Okay, thank you very much. And we have an action to take away from this, that we, at the appropriate time, when we've got the information that's required, we will have an informal best value session with Anne MacDonald or colleague to allow the IJB to explore the best value package, if you like, that we need to be considering alongside continuous improvement, and hear from the audit committee how they would maybe propose to take that forward. So that would be an action from this discussion. So thank you very much. We move then to item 7, where we have the Health and Social Care Partnership Performance and Outcomes Framework for Q3 and Q4. So Angela MacLeod is with us. So Angela, would you like to introduce the paper, please?
Yes, thank you. Good morning. As you've described, this is the performance report for both Q3 and Q4. Due to items understandably having to be deferred from the March IJB meeting as a result of our response at that time to COVID, we are presenting both the Q3 and Q4 at this meeting, so apologies for the delay, and also that it's a far lengthier report this time round. The report provides our performance against our usual suite of local indicators. So it is continuing in the same format as previously. Under section 6, we're describing some of the work that we will now be recommencing, again, which has been paused as a result of recent events. But with the board's agreement, we would be proposing that this now concludes the 1920 financial re-reporting in this format, and that we now pursue the development of the new reporting framework, which we would plan to report to the IJB later in the year. But in the interim, it's proposed that we hold a workshop with IJB members to understand what it is, or to present some initial thoughts on what that might look like, and to get your feedback on that process. In the interim, you'll note appendices 2 and 4, which provide the exception reports against indicators where performance has fallen out with target. These follow similar trends seen earlier in the year. However, in particular with regard to Appendix 4, we have noted the resulting impact of COVID that has in particular had a significant impact on our performance against delayed discharges and also ED attendances, for reasons that you will be aware. So although in these 2 areas we were performing out with target, the performance has obviously changed substantially since Q4 reporting. But we felt relevant to provide that context as to the changes brought about by COVID. We also mention in the report with regard to the annual performance report, which would normally be due for publication at the end of July, that there have been various national discussions, which unfortunately we didn't have the up-to-date information available for this report, but we will bring back a proposal with regard to delaying publication subject to the IJB's agreement, and that is consistent with other IJBs in Scotland at this time.
So, thank you very much, Angela. And just to finish off the point that you've just made, because there's been a delay agreed nationally to the annual report being submitted, that is to be submitted by the end of October at the latest, but we are required to formalise that delay. So to that end, there will be a date will be circulated to members, and it will be before the end of July, where we will need to have a formal meeting to actually put that into place, and that's a requirement that we have in terms of governance and legislation. So thank you for that, Angela. So members, do you have any questions on the performance information before you? I see no questions, Angela, but again, just to oh, beg your pardon, Rhona?
Yeah, it's just to say that looking forward to the workshop and the performance information that we will develop, because there's no point in going over what we've got, because we know where it's deficient. So I'm really positive about looking forward and building up what is going to be of use to us. So thank you for including that, and the sooner the better.
Thank you for that. I've got Provost.
Thank you. Yeah, just a small point. It's a very helpful report, and I was just looking at 6.2 about trying to get hold of requirements and expectations from individuals. But I'm comforted to see that in under 1.2 of the recommendations that this will be circulated to the area committees, and I think, as always, that's a useful mechanism to pull in some more thinking before we take this further. So that's just a helpful comment. Chair, thank you.
Thank you very much, Provost. Feedback. Thank you very much indeed for that. And I wonder if it's an opportunity to ask, if there's a report going to area committees, to ask locality managers to go along with that report and actually try and put into some sort of context what is required by local area committees in terms of reporting, so that we can actually get it all considered at the same time. Because if we develop a suite of information that we then have to tailor later for other partners' needs, then I think it would be helpful to try and get some indication as to what local information would be required and try and work that round at the same time. But thank you, Rhona and Provost, for your comments. And Joyce agreed with the point that Rhona made as well, and Angie has indicated that she'll be happy to ensure that that additional ask of area committees is included. So with that, I don't see any other indications. Yes, the Provost has indicated that involving locality managers is really important at a local level, so I think that's really helpful, and alongside Mark's work, locality managers are have an opportunity to refresh their local performance, local plans and performance information as well. So thank you very much indeed for that. So can we agree the recommendations? We've had the opportunity to comment on the content of performance reported on quarters 3 and 4 against the commissioning plan, but and that's by exception, and endorse the report for circulation to area committees for their information and reflections, and any feedback will be shared with IJB members in the future to ensure that interactive process. So with that slight amendment to the second recommendation, can we agree the recommendations, please?
Agreed.
Okay, thank you very much indeed. We turn then to item 8, which is the finance outturn for 2019-20, and happy to invite Mr. Sharp to speak to the paper, please. Thank you.
Thank you very much, Chair. Yes, so the report you have in front of you covers the financial year which ended in March. the IJB recorded an overspend against its budget of £5.6 million, which is equivalent to about 1.7% of the total budget. And this compares to an overspend for the previous year of £3.1 million. So the position worsened during 2019-2020. In financial terms, the last year was much more challenging than expected, and an overspend of this level is definitely not a positive outcome. The overspend does need to be seen in the context that we had a 2.2 million savings programme, which was set as part of the budget, and we think we achieved 1.3 million of that in terms of actual savings. Unfortunately, throughout the year, we were not able to mitigate the significant budget pressures, especially on the social care side of the budget, where demand for residential care and home care continued to increase in levels that were well in excess of the funding that we had available. So our most significant areas of financial pressure are outlined in the report. The biggest area of overspending was on older people care management, which overspent by £2.4 million. And that was largely due to the fact that we had 49 additional care home places on average during the last year, and we had a 9% increase in care at home hours during the last year. Adult services community care also overspent by almost £2 million, and that was due to largely increasing numbers of high-cost complex packages that came throughout the year. And our other large area of overspend was around community hospitals, which overspent by just under £1 million, and that was due to pressure around nursing costs, but it was an improved position on the previous financial year. So as per the integration scheme that we have with our partners, we now have to formally request additional funding from them to meet the overspend in line with their respective shares of the budget. So that equates to £3.2 million from NHS Grampian and £2.4 million for the council. Both of the partners are already aware of these amounts and have built them into their financial positions at the year end. But I would stress that this is not a straightforward thing for them to do. They don't have a bottomless pit of funding that they can give to the IJB, and so they have been forced to find efficiencies in other areas of their budgets to fund the overspend. As part of our year-end position, we also have a small earmarked reserve of £117,000, and that's for a slippage of funding against specific earmarked allocations that we get from the Scottish Government for the Primary Care Improvement Fund and the Action 15 mental health money. And that money will be spent on those two areas in the current financial year. So in March, we set the budget for the new financial year on the 25th of March, and that included a savings programme of £5.5 million. The budget that we did set at the time has now been largely superseded by the impact of COVID, and we've been recording the cost of COVID for our submission to the Scottish Government on a regular basis, and we're currently anticipating full funding for those costs. Our current estimate of those costs, of the additional cost, is £10.3 million, but this figure will change as the months progress throughout the year. And I aim to submit a refreshed budget to the IJB in August, which takes account of the COVID impact and also the first set of results for the new financial year. So I'll pause there and happy to answer any questions.
Thank you very much indeed, Alan. I have a question from Councillor Ross, please.
Thank you, and thank you for the information, Alan. My question is, and it's more of a generic, thought-provoking question, that perhaps there are statutory things we have to do as an IJB in Health and Social Care Partnership, but perhaps we need to be revolutionary and looking at everything that we are doing and to see what we have to do. And when I say nice to haves, they're not nice to haves, because there are lots of things that we do through third parties which are delivering care, etc. But we need to have a look at everything and just stick to certain things, to our priorities perhaps, because our position's not sustainable. You're right, as far as the council are concerned. We've got some very tough decisions to make as councillors regarding the council's budget, but equally we're not exempt from doing that as an IJB either. So thank you.
I can respond to that if you'd like, Chair.
Thank you.
Yeah. So no, thank you, Councillor Ross. We're absolutely very aware of the financial position of our partners, particularly the council, who seem to have been very badly hit by the financial impacts of COVID. So we're aware that as part of our restarting services programme, we need to look probably in a more challenging way at what we can and can't do within our funding envelope.
Thank you very much indeed, and I think the issue around statutory and discretionary services is absolutely part of the review that we need to take forward, and we do need to look at absolutely everything. So I think we'd all agree that that is the way forward. I now have Provost, then Rhona, then Joyce, please.
Yes, Chair, a question and a comment, if I might, please. Page 52, out of area overspend, £541,000. I mean, we've seen the like of this coming before. At what level, who actually signs off that amount of money in terms of the issue in Northumberland?
Chair, it's Mark. I can answer that.
Sorry, hang on. We've got some echo. So, Provost, sorry. Okay, thanks. I'll take Alan and then I'll take Mark. Thank you.
All right, I was hoping Mark was going to answer that. That's difficult. I can answer some of it, but Mark can give you the clinical context.
We can certainly go to Mark first if you wish. It's up to yourself. Mark?
Thank you, Chair. So it's important to stress that this column is out of area inpatient provision. We've made a lot of progress in terms of out of area social care provision, less progress in terms of out of area inpatient provision, because that fundamentally requires redesign at Cornhill in terms of our inpatient beds. And we do now, given that that Cornhill is now hosted, we do have an opportunity to do that. In terms of the technical answer to the question, it's signed off by the consultant psychiatrist, by the clinical lead, and then by one of the partnership managers. And it is extremely expensive. It tends to be people that can't be looked after at Cornhill usually because of their challenging behaviour and the complexity of their need, and they need a semi-secure environment.
Thank you, Chair. And I wanted to make another point, if I could.
Carry on, please.
Yeah, it's not in any way to prejudge the recommendation at 1.3, but one of the factors I think we shouldn't forget in terms of working together is that we have, over the years, built up a very good working relationship with the Council and other authorities, and I think we should be mindful of that. I'm all for looking at different ways of doing things, no issue with that, and we've got to do that. But when I was looking at some reports yesterday that the Audit Committee will be looking at later today, and if you look around, a lot of authorities are struggling to take forward the integration plan in a way that was hoped. So all I'm saying is they're tough times, but we have a pretty firm basis that we've been working on for the past few years, and I hope we can take that forward in the best spirit of joint working. Thank you very much, Chair.
No, thank you very much for those words, Provost. I think we'd all, again, concur with that, absolutely. Alan Sharp, do you want to come back at all before we move on to other questions?
No, I would just echo what Mark has said. I mean, these packages, these out-of-area packages, tend to be for particularly complex patients, and they tend to be hugely expensive. So that overspend that you see on that budget of £500,000, that's probably a couple of packages.
Okay, thank you very much indeed for that. I now have Rhona, Joyce and Amy, please.
Thank you, Chair. In a sense, I'm following on where Anne and Bill have taken the conversation. I'm glad that Alan highlighted that our NHS and local authority partners have actually started to raise questions about what they're funding by way of an overspend. It's been coming for years, and I think both organisations, like ourselves, are struggling to balance the books at the end of the year. So it's not unexpected, and almost a relief that we're getting to that point in time. I do also echo the point that Bill has made, that we do have good relationships with both those organisations, and infinitely better than I think many IJBs have elsewhere in the country. However, within the very good report we got from Alan, there are some items where there's overspend, where the solution lies with the IJB board itself, and therefore I build on Anne's point that we do need to make some very tough decisions going into the future of budget setting and of the current financial year in terms of how we get to a more balanced position. There's no point in trying to give services to people if we haven't got sustainable amounts of money by which to do that. And if to get to a sustainable position we have to find other ways to cover everything that needs to be done, and therefore not necessarily by the IJB, then that is something we really have to look at long and hard. But I think COVID has brought a lot of things our way and changed a lot of thinking, and hopefully it will give us the fresh eyes to come forward with a much stronger and more sustainable budget for the future, having taken those tough decisions. Thank you.
Well, you're absolutely right. Thank you very much for articulating that. It's absolutely the position that we're in. Thank you for that, Rhona. Joyce, and then Amy, please.
Thanks, Chair. Really just wanted to concur with what Rhona and others have said there. I do think that going forward we need that very different look at what we've been doing, but also wanted to confirm that I think we're in a unique position in terms of integration. We do have very good relationships, which we should be not only thankful for, but appreciative of the hard work that's gone in to achieve that. And also wanted to thank Alan for the rigour and quality of the accounting information which he puts forward. Although I don't like the end point, I do appreciate the work that's gone into it. Thank you.
Thank you.
Thank you very much for those remarks, Joyce. I think we'd all concur with that, absolutely. Amy, you have a question, please.
Thank you, Chair. Yes, it's regarding the Alcohol and Drugs Partnership. On page 48, the underspend due to the difficulties in getting projects started. And on item 7, we saw that there have been delays on alcohol and drug interventions as well. Is this raising alarm bells, and have we got a process for managing the risks around these delays, given that people have just, it's still in lockdown, so we haven't got their face-to-face supports for their substance misuse issues, and we know that there's more drinking going on generally. Have we got a plan to kind of mitigate the risks around this? And an ADP needs some sort of, do we need to be speaking to ADP about these issues? Thank you.
Mark, please.
Yes, Chair. So I think two separate issues there. I think there is a question about how we organise the ADP and how we support the ADP to move forward, because part of this underspend, as welcome as it is in some ways, comes from delays around the procurement process, etc. So there is a question around how we organise the ADP, and I've had some interesting discussions with Luan around that, and we're meeting again next week. And I think we will formally commission a review of how we support the ADP along with HR and the trade unions. In terms of the waiting times, Amy, the failure to meet the target is slightly misleading. When we realised the increase in drug deaths, I gave the substance misuse teams a specific instruction that there should be no unplanned discharges from the service, because we know that it's when people fall out of services that they are at greatest risk. That has an impact on the statistics, but I think I would argue that means we provide a much more assertive type service. So, for example, some partnerships will simply send somebody a letter with an appointment time. If they don't turn up, the case is then closed. That makes it very easy to meet the target. We don't do that. We go after people. We knock on their door. We track them down in the streets sometimes, etc. And I think therein is a bit of tension between outcomes and waiting time targets. And we are in discussion with the Scottish Government. I will chase that up now again as to how we can overcome that in terms of our reporting. But in terms of capacity of the service, in terms of outcomes of the service, I think we're in a fairly good position.
Thanks, Mark.
Okay, thank you. I have Fiona Culbert, please.
Hi, it's just from a carer's perspective. It's like page 55. You're discussing overspends, but just say, like, I find it quite concerning that it's kind of blithely put that offsets are put by underspends in respite and also in use of SDS, which is the most effective, cost-effective delivery of social care. It just, you know, the message is not getting out, and all the research that's coming through just now from all the independent care organisations is that, you know, carers are really struggling, and outstanding in Aberdeenshire already is the respite briefing review. You know, it's just an area of concern that there's a lot of work that obviously needs done on the efficacy of SDS and also provision of support for carers. It's just to keep that well and truly on the agenda. It will link into obviously further discussions hopefully on recovery, but relating to that what is marked from my perspective is there's an absolute lack of any lived experience in the membership of your recovery team.
Can somebody, Mark, please?
Thank you, Chair. I absolutely agree with everything Fiona has said in terms of self-directed support. We do everything we possibly can to encourage people to take direct payments or option 2 whenever we can. The uptake is still relatively low because it was never just about that. It was very much about being person-centred and putting people in control. But if there are any suggestions from carers or from people with lived experience of how we promote that further, then I'm very, very happy to listen to that and to learn from it. And I think every social worker would say the same thing. We recognise it's important to say that no, we've not paused respite or entirely paused day services. We are still actively supporting people wherever we can. Respite is a priority to restart. However, it's also one of the most complicated areas because taking 4 to 6 strangers into a building is not particularly advisable, given that we know some of our buildings are older and don't particularly lend themselves well to social distancing. A lot of the people that we support will struggle with the concept of social distancing, etc. So we are actively looking at how we can get more capacity around respite. That includes how we increase SDS direct payments, and it also includes how we can work better with commission services as well. So I would say respite and day services are 2 of the services that we're most keen to increase capacity over coming weeks, but it is incredibly complicated. And I'm very happy to welcome a carers rep onto the recovery group. The membership of that group is evolving all the time. Thanks, Chair.
Thank you, Mark. And before I come back to you, Fiona, Alan Sharp would like to come in, please?
Yeah, it's probably just worth making the point that underspend on SDS is not something we've deliberately tried to manufacture. We set the budget on what we think may be spent, and in the context of a £300 million budget, we have some services which overspend and some which underspend, and SDS is just underspent this year. It's not something we've deliberately tried to achieve. We've funded the service to what we thought it was going to spend.
Fiona, would you like to come back?
Thank you for that from both of you. Yes, I think it's definitely time to have more representation because you keep on talking about co-production but we're not actually seeing it. The SDS champions do not actually have any representative apart from professionals. Going back to you, Alan, as well, it's just like it was never the interpretation that it was a plan to have the underspend, but again, it shows that there is perhaps something not working efficiently in the service if you have such a substantial underspend. The communication is not getting out potentially to carers. So it is an area which is obviously not point to have a discussion today, but I really strongly feel this has to be kept on our agenda because unpaid carers are the lifeblood of social care. I can't keep reiterating this, and we need more information directly from IJB, and we also need more involvement in the decisions that are being made. because it is not just all about option 2 and provision of service, it is also looking at your direct payments and how to develop that. So thank you.
Thank you, Fiona. Now, this is not the first time that Fiona has raised the issue about communication to carers groups and to carers, and the issue around unpaid carers that has been raised previously. So in the first instance, Mark, are you happy to discuss with Fiona off table the issue of representation on the recovery group by a carer representative?
I certainly am, Chair.
Okay, thank you. And can we put in place a discussion, if Fiona's willing anyway, and maybe George as well, but certainly Fiona, can we get somebody to organise a discussion with Fiona around communication, where the communications go, are we making sure that all groups that require to be reached are being reached, and can we just put a check in there, actually we are able to cover as many bases as possible in terms of communication. Can I ask, oh, Angie has a comment. Thank you.
Just to say I'm more than happy to pick that up, Chair, and make sure that's done.
Okay, thank you, Angie, and maybe with Joe. Oh, yes. Joe's saying there's an information officer for carers, so it might be worth setting a meeting with that team. So again, Fiona, are you happy to be included in any conversations that are required?
If I get alternative care and respite, yeah.
Fair comment, but I mean, again, it's just you know, if people can get in touch or can organise an online discussion, are you happy to try and if it's not yourself, you might want to nominate somebody else who could do that too. So you know, if you know somebody that could actually take that place, then that would be really helpful. So Angie, can you'll take that off table with Joe?
Absolutely, absolutely. I think if there was easy solutions, we would give them, but there's not. So I would really welcome the input to try and work through what our options are around many of these really difficult ones, as Mark's described.
That's helpful. So Fiona, somebody might be in touch, but you may want to nominate somebody else if you're not available. Okay. Thank you. Okay, thank you very much indeed for that. Now, there was an interruption in the connectivity. I don't, on the new screen, have any other indication, so please shout now if you want to make any further comments on the finance paper, please.
Chair, Dennis here.
Yes, Dennis.
It's just on the community hospitals, and I'm just wondering if in terms of staffing levels, etc. as well, if we're still working on a plan and trying to readdress how we use our community hospitals. I'll just leave it there, Chair. Thank you.
Thank you, Angie. There's a bigger piece of work. I mean, again, members have had this information through previous sessions, but Angie, there's a bigger piece of work around community hospitals.
Absolutely, something that we've certainly been considering through the entirety of the COVID response. You know, there has been a lot of work done around actually, I suppose, reassessing our whole estate in terms of infection control, in terms of appropriateness, in terms of what are the options that we could utilise to deliver the best possible whole system approach through this time. So I think COVID has probably escalated some of those conversations and meant that we've had them with a greater maybe buy-in from all parts of the system. But that would certainly build very much through the work that Mark will discuss later around resetting, rebuilding. I think that there is a whole conversation about what COVID now means for the ERI site, for example, and actually how could we utilise our resource slightly differently. How do we use technology to be able to deliver that care much closer to people's homes, potentially with the support from teams within our community hospitals, maybe not necessarily our own teams, but actually maybe more outreach from the acute sector, work around elective care that again had been started pre-COVID. Maybe just need to refocus some of that work and think about what the opportunities, as I say, the technology probably gives us that we didn't have before. So I think we're entering into this period of living with COVID where we'll have, yes, more opportunities, potentially maybe different constraints, but pieces of work that need to be done. So there's quite an extensive review of all of our estate going on at the moment. Again, going back to Lizzie's comments about infection control being really key to that. Yes, hopefully we'll get through this COVID experience, but that's nothing to say that another pandemic is not around the corner. So I think we need to take a really rigorous look at all of our facilities and start to think about how we make sure that they are fit for current purpose, but also really importantly fit for the future as well.
Thank you, Angie. I don't see any other indications, and thank you for the question, Dennis, but can we go to recommendations, please? The recommendations ask us to consider and comment on the financial position set out in the report and in the appendices 1 and 2. Sorry, I think we've got feedback. To approve the budget adjustments detailed in Appendix 3, to formally request that NHS Grampian and Aberdeenshire Council fund the reported over budget position for the year ended 31st of March 2020. Can we agree those recommendations?
Agreed.
Agreed.
Okay, thank you very much, and thank you to Alan, Sharp and teams for all the work that you do in terms of financial management. Thank you so much. Members, I would ask you now if you wish to take a comfort break or if you wish to proceed. I'm in your hands.
I'd be quite happy to proceed.
I'm actually quite happy to take a 10-minute comfort break.
I agree with Dennis. That would be great. Thank you.
Okay, so it's 11:38. We will have a 10-minute comfort break and resume at 11:50. You have 12 minutes. 11:50. So with that, we will see you at 11:50. And we will have next on our agenda, item 9, the clinical and adult social care governance. There is a paper before us which asks us to appoint members to the Clinical and Adult Social Work Governance Committee to cover the post of NHS Grampian representative, a council representative and a public or carer representative, which accords with the approved terms of reference for that committee. We're also invited to appoint a chair of the Clinical and Adult Social Work Governance Committee from the 4 IJB representatives and appoint a deputy chair of the Clinical and Adult Social Work Governance Committee from the 4 IJB representatives. So that is the ask of this paper. It sets out the purpose, etc. So I would seek to move to the appointments in the first instance. Do we have nominations, please? Oh, sorry, before we go to that point, Joyce has asked a question and asking who is on the committee at the moment.
Chair, if I could maybe come in, I don't know whether Geraldine obviously prepared this paper, so maybe Geraldine could answer any specific questions that are around the committee structure at the moment.
Yes, thank you, Chair. So we do have the new terms of reference, which, as set out, includes the 4 members of the IJB, and we have 3 vacancies at the moment. So we do have a third sector member, Sue Kinsley, who is on the committee. There are also some officers that are on the committee as well. So that includes the chief officer or her representative, also the chief social work officer, Ian Ramsey, and also the chair of the Clinical and Adult Social Work Governance Group, which is meeting weekly just now. There is also a Quality Improvement and Assurance Facilitator and a Strategic Development Officer. So that is the officer support that's around the committee just now.
And just to add to that, can I say that Councillor Anne Ross was the chair previously and indicated some weeks ago that she wished to step back from that. So, and indeed from the committee. So I'm presuming that's still the case, Anne?
Yes, I understood that I had to step down because I've been doing it for, actually I did it over 2 years, but the chair can only remain in situ for 2 years and then they have to step down. So if I hadn't had to step down, I'd have probably carried on, but I do have to step down because that's what the scheme of governance for it says. Yes, I'm happy to step down. I enjoyed the committee. It's a fantastic committee and I enjoyed my involvement, and I would like to thank everybody for their support when I was doing it.
Thank you for that, and indeed that we'd like to thank you for the work that you've done in that position. It was new to everyone, and I think it's such an important aspect of what we do is for the assurances in terms of the clinical side of things. So thank you very much indeed. So Rachel, you have indicated you wish to speak, please.
Thank you, Chair. If it's possible, I'd like to put myself forward as the nomination for the NHS Grampian representative on the committee.
I will accept that nomination. Thank you very much, Rachel. Can we have a seconder for that?
Dennis, you're happy to?
Okay.
And also myself.
Okay, thank you very much. So thank you for that, Rachel. We need a representative from the council. I wondered if Provost, were you interested in clinical governance at all?
Yeah, I don't really have a heavy workload. I suppose I could squeeze it in. Yeah, I mean, I don't. How often does it actually? I'm just looking to see if it how often it meets. Let's see the
Geraldine.
Yes, thank you, Chair. So the terms of reference provides that it should meet quarterly. However, it is at the discretion of the Chair to hold additional meetings, and perhaps with a view to the committee reconvening during the COVID response, it might be appropriate to hold some additional meetings, but quarterly would be standard.
Provost?
If that would be helpful, I'll take up that. Yes. I mean, I would need to stress that. I mean, if I was asked to do it, I'd want to make sure I had diary entries well in advance, as everyone else is, because I mean we are busy times. But yes, I would take it up. Yeah, if that's helpful. Thank you, Chair.
Thank you for that. Well, oh, sorry. I think we've got echoes. Anne, could you have done yourself as well? Yeah, thanks. Thank you. So with that, I'm happy to nominate Provost. Can we have a seconder, please?
I will.
Thank you. Thank you very much, Anne. And Angie Much has indicated she would like to be considered as the nominee for the public rep. You have support for that, please?
Yes.
Yes.
Okay, I think it was Joyce I got, and then Dennis. So with that then, at recommendation 1, we have a representative from NHS Grampian from the council, and for the public representative. So that would be Rachel, Provost and Angie Much. Will we agree those, please?
Approved.
Agreed.
Thank you. We're then asked to appoint a chair of the Clinical and Adult Social Work Governance Committee from the representatives. Can I take the opportunity, please, if you would permit to nominate Rachel?
Agreed.
Second that.
Okay, Rachel, are you happy?
Yes, thank you very much, Chair.
Okay, thank you very much. And can we appoint a deputy chair, please, from the representatives? Again,
I'll nominate Angie for that.
Well, thank you, Joyce. I was just going to do that, but I thought I'd give somebody else an opportunity. I'm happy to second that nomination. Angie, are you happy to do that?
Yes, that'd be great. Thank you.
Okay. So with that then, colleagues, we do have the recommendations. We have appointed to the appropriate places. So can we just formally agree those, please?
Agreed, Chair.
Agreed.
Okay, thank you.
There's one point, Chair, if I might.
Of course.
The Chair obviously would have to try and give us some indication of dates going ahead, so I'm sure we could take that forward at some point. Thank you.
Rachel, are you happy to give some advance notice of meetings, please?
Yes, thank you, Chair. What I'll do is I'll link with the officers who are aligned to the committee, and I will ensure that we get some future dates put out for people to respond to.
That's great. Thank you very much. Sorry, Dennis, I'll come back to you, but I was just going to ask Geraldine if she would be able to put an introductory pack together for the members, please.
Thank you, Chair. Very happy to do that. We're already working on an induction session, and we'll probably make that available to the whole committee as a refresher as well.
That's brilliant. Thank you very much for that. Dennis.
Very quickly, Chair. I'm just following up the Provost's point. If the Provost does find it onerous and feels he can't take up the position at a later date, I'd be quite happy to nominate myself if the board agree.
Agreed. We can certainly come bring something back, Dennis, because that would need a formal paper. So we will work on the basis that if there's an issue, then we can come back to the board. Okay, thank you very much for that. Okay. Sorry, we move then to item 10, which is the initial report on resetting and rebuilding. And this is the piece of work that Mark has been taken forward, Mark Simpson's been taken forward in light of the COVID-19 outbreak. And apologies for the lateness, but I agreed that a supplementary paper could be circulated to members so that you had all the information before you today. While Mark was introducing the information to you. So can I just ask Mark to take the reins, please? Thank you.
Thank you, Chair, and good morning, everybody. This paper, I think, essentially does two things. Firstly, and probably most importantly, it sets out the high-level approach we propose to take in terms of the recovery from COVID work. And we are asking the IJB to formally endorse these principles. In addition to that, the paper also gives a summary of the feedback we've received from what was a series of workshops we recently held with staff, frontline staff and team leaders in an attempt to capture some of the early, and I do stress early, lessons learned from our initial response phase to COVID-19. I said quite a lot about both of these areas at a recent informal meeting, so I probably don't need to go over that in any great detail again. However, as you'll see, we have 4 subgroups of the recovery cell, and if I may, I'll just quickly say a wee bit about them. The first is looking at scoping this idea of the health and social care debt. I don't think debt's quite the right word. We haven't quite found it yet, because there's clearly opportunities there as well, particularly what we've just been discussing in terms of increased self-care and self-management, etc. But we know that many people have stayed away from services, even when services have been open. And this subgroup is tasked with scoping and interpreting what that means for us. They will also consider the impact on health inequalities, which I think is very important. And perhaps Kim will say more about that in her paper that follows. The infrastructure subgroup, which is essentially looking at all things physical, for want of a better expression. So looking at our buildings, looking at our ICT, looking at transport, etc. Transport is going to be a particular challenge moving forward. The commissioning group will look at how we might need to adapt our approaches to commissioning in the months ahead, how we coordinate communication with commissioned services, and also provide us with some intelligence as to what's happening within the wider social care market, which we know is struggling at the moment, and it will continue to be a challenging time for the wider social care market. So that communication, which I think has improved dramatically over recent months, is something we want to continue. And finally, engagement and communication. This is both about how we communicate with stakeholders over how we're going to navigate this next phase, but also about how we can learn from the dramatic increase we've seen in volunteering and the increased community resilience, which we're obviously keen to learn from and to embrace. Chair, one final comment, if I may, which is more general terms about how I see this recovery cell taking things forward, and perhaps about what members can expect to see in forthcoming meetings. I increasingly think, and this is a personal reflection, but I increasingly think there's three tiers to this recovery work. Firstly, there's the process of identifying and embedding all the positive changes that we've already made. And that's something that's already happening at a location level. Secondly, there's also the question about how we used these experiences over the last few months as a springboard back into our wider transformation agenda, recognising that we're starting from a very different place. So I would suggest that I don't feel that our strategic plan necessarily needs to change, but we're definitely starting from a different place. So perhaps a need to bring back, and I would be interested in views on this, but there's perhaps a need to bring back an updated strategic delivery plan. Perhaps that needs to be linked to a medium-term financial strategy. And finally, and this is our priority at the moment, probably the most urgent and also the most complex part, is that we need a plan, a fairly operational plan, as to how we're going to navigate the next 12 months, this living with COVID phase. And Chair, I think that's partly about remobilisation, as we've touched on, but it's also partly about business continuity. I think it's also partly about winter planning. The government may disagree, but I'm not sure it makes much sense to have a standalone winter plan this year as we would normally, given that COVID will play a part of that, and perhaps also an element of financial recovery too, depending on what the likely settlements are going to be in terms of our additional COVID expenditure. So I could probably talk about this for all day, Chair, but on that note, I'll pause and I'll be very, very happy to take questions. Thank you.
Thank you very much, Mark. And I have Councillor Glenn Reynolds and then Amy, please.
Thank you very much, Mark, for this and all that you and the team are doing. It's a comprehensive piece of work and there's a lot of information obviously there. So I'm just going to sort of cherry pick one particular aspect for and seek some reassurance in light of the uncertainties, to say the least, that we're faced with regarding the COVID situation and the potential for the winter situation and second spikes and all the rest of it. So I'm looking at page 69 and I'm just focusing on the references there to the stresses and anxieties surrounding deployment of staff, redeployment of staff, and basically in principle the movement of staff around, and a reassurance sought that Scottish Government advice regarding limiting that in light of the COVID situation and the potential for seeding and transference. We don't know what the situation or what the landscape will be, but I'm just a little bit concerned and seeking some sort of assurance that is fully incorporated, that the Scottish Government advice, which is specifically against the transferring of staff from one place to another. So if you could just comment on that, please. Thank you.
Thank you, Councillor Reynolds. I think we touched on this briefly at the area committee the other week, didn't we? Yeah. So I think we're starting from a very different place this time. So testing is now much more comprehensive, as you'll be aware. So if we are moving staff on a planned basis, we probably do now have the capacity to make sure that testing is in place before that happens. I would just say in terms of staff anxiety, I think there was almost, and I don't want to appear, we can certainly learn the lessons from this, but I think we had to act very, very quickly. I think there are lessons we can learn. I think there's work we can do with the staff team in terms of preparing them for the fact that they may need to be deployed at very short notice. But in specific response to the question, we would, if we are moving staff on a planned basis, then we have the capacity in terms of testing, and we have an opportunity to prepare staff carefully for that.
Thank you very much.
Is that okay, Glenn? Would you like to come back? Are you okay?
No, that's the reassurance that I was seeking. Thank you.
Okay, thank you very much. Amy, please.
Thank you, Chair. I'm just wondering, did Joanna Harold have a question? She's in the chat, but I'm not sure.
No, Joanna's putting up the titles of the report.
Oh, I see. Okay.
As we've been going through. So
Okay.
Joanna's making sure that we've got the titles of the reports for the, because this will all be on the recording as well.
Oh, I see. Okay. All right. Thanks for
Okay.
clarifying that.
Thank you.
Yeah. Thanks, Mark, for this piece of work. It looks really helpful. It's good to get a bit of granularity over what staff are saying and the sort of gripes they had and the stuff that works really well. So thank you very much for this ongoing piece of work. I guess the kind of defining way of working was working in partnership during the COVID crisis, working with the local resilience groups and the third sector and communities. I was wondering whether, are we listening to their lessons learned and their gripes and what they thought worked well, and are we thinking about the third sector as we develop our commissioning for the future, because it seems that they're going to be even more important to help us deliver our strategic objectives. So are we working with our third sector and communities to share the learning and move forward together?
Thank you, Amy. So the subgroup on communication and engagement, I've asked Kim Penman to chair that. Kim was heavily involved around the COVID hub, etc. And I think Kim will take a lot of experience from that into chairing that subgroup. We also have Dan from AVA as part of the recovery group, etc. We also have, in terms of services that we commission in terms of the wider market, we had already started a significant piece of work working in partnership and co-production with the social care market around how we commission home care and supported living. That was put on pause, but over coming weeks that will restart again. So I think we've got a pretty reasonable representation there, but it's certainly something we'll keep a close eye on.
Thank you.
Okay, thank you. I don't have any other written indications of people wanting to speak. Does anybody else? Just please shout.
It's
Okay.
Joyce here. I just want to say,
Joyce.
Sorry, I just want to say thank you to Mark for that synopsis, which was terribly useful, and apologies for requesting it at the last minute as well. But it was great to see that. It helped me clarify things.
Thank you, Joyce. Does anyone else have any other comments or questions for Mark? Are we content with the direction of travel? The recommendations on page 64, I think it is. We are being asked to comment on the draft principles for recovery outlined at section 3, and if in agreement, formally endorse them. Consider the feedback from health and social care staff on early lessons learned, which is at appendix 1. And agree to receive regular updates on the approach being taken to resetting and rebuilding. Can we agree those recommendations, please?
Chair, can I come in?
Oh, sorry. Amy?
Thanks, Chair. Just based on the feedback Mark just gave us on working with the third sector, I wonder whether, say, 1.2 could be strengthened to include getting feedback from the third sector and key stakeholders moving forward.
Mark, is it your intention to include further feedback in the reports that we're going to receive, or how do you want to take that forward?
We can certainly factor that into the next report that we bring. It is definitely happening. We just didn't have it in time for this particular report, but we'll certainly factor that into a future report.
Okay, so can that go in the wording of the recommendation?
I've certainly no issue with that.
Okay, thank you.
I think it might be helpful rather than pick one or two different stakeholder groups, that actually, Mark, could you give us a timeline and some sort of key milestones where we can expect updates and reports so that it is actually sits more strategically? Because we've heard earlier today about unpaid carers, and you know, so I just wonder if it would be helpful for members to have some sort of timeline so we know when to expect some of the key matters that you're considering in report form. I just wonder if we can actually set something out which would be more transparent, if you like, for members, so that rather than just choose one or two.
We have a meeting of the recovery cell tomorrow morning, and we can certainly do that, Chair. There's no difficulty with that at all.
Okay, and Amy's saying that would be helpful. Angie, do you want to come in, please?
Yes, Chair, if I may, I think we've always picked up from the IJB a real desire for us to simplify and streamline things wherever possible. And I think certainly some conversations that Mark and I have been having is how can we dovetail this work very quickly into almost our normal business. So I think there's probably a conversation for us to have around the strategic planning group in particular, and that strategic delivery plan that Mark mentioned. So I think we're at a point quite soon where actually we need to establish this into our normal day-to-day business. I think the COVID response is going to be of such a length of time that actually we do need to utilise some of our mainstream structures as well. So I'm keen to have a discussion with Mark about how we maybe present some proposals going forward for how the strategic planning group may look like going forward, how that strategic delivery plan sits, and what assurances we can give to the IJB that actually the strategic planning group is delivering what the IJB requires of it, and for my senior management team, what we as a team and what all of our staff requires of it as well. So keen to take that work forward as well, Chair, if I may.
Yeah, that's fine, Angie, but I think when we try and pull everything together and pull everything into one, I go back to the point, I think it would be really helpful to have a timeline and a clear view of the work streams and where, because the medium-term financial strategy, the updated delivery plan for the strategic plan, this remobilisation and resetting papers, the strategic planning group, etc. So it would be helpful to see all of that in one place, so that we can understand where the work streams are, when they're expecting to report, what they're expecting to report, and maybe things that can be actioned more quickly. So I think it would be helpful. It would be helpful for me. I take guidance from others to set that out in a simple form, so that we all can follow the progress. What would others think?
That would be extremely helpful.
I agree.
Yeah, I would agree as well, Chair. Yeah.
The simpler the better, Chair. Thank you.
That's what I was thinking, Councillor Robertson. I think simple would be good for me. So can we take that forward then? If officers can actually develop that and set out just exactly
Absolutely.
What we should expect when would be helpful, bearing in mind the ask about third sector, etc.
Absolutely, happy to do that.
Okay, that's fine. Can we agree the recommendations then as previously described with those additional actions, please?
Agreed.
Okay, thank you very much. Item 11 on our agenda is the Equalities Mainstreaming and Outcomes Progress Report and the new Equality Outcomes, and that is from page 74 on your pack. Can I ask for an introduction to that paper, please?
Hi, good morning. It's Kim Penman, so I'll speak to the paper. Hi.
Morning, Kim. Very welcome.
Hi. So this equalities report was actually prepared for the IJB to consider back in March, so that we were in line with our legal requirements. Unfortunately, obviously, as the pandemic emerged, that wasn't possible and the IJB wasn't able to consider the report. However, I think because of the kind of sharp focus that COVID-19 has placed on the kind of inequalities issues and agenda, I think it is very timely now that we consider the work that we've been doing over the past, but obviously looking to the future and what we need to do. In terms of the inequalities in relation to COVID, both there has been a disproportionate experience of certain protected groups, for example, older people and black and minority ethnic groups in terms of their experience of the virus itself, but also as we emerge, the economic impact of COVID will also be experienced disproportionately by certain groups of people, for example, young people, women, etc. So I think it is really timely that we really consider what our response to equalities agenda is. We haven't made further changes to the report since it was produced in March, but what we would be proposing is that we do a recast, bearing in mind that we do need to look at how our services are emerging slightly differently, and so we do need to make sure that our actions around equalities reflect that as we go forward. So what we are proposing is that we would provide a further recast to supplement what we've produced here, but I think in terms of our legal requirements we'd be keen to get hopefully this approved so that we can publish and be compliant with legislation. The report provides a description of the work we have achieved in 2 years between 2018 and 2020, provides a narrative but also a series of case studies that hopefully illustrate how the partnership has been delivering its equality outcomes to date. And then it also sets out 4 proposed outcomes for the next 4 years, for 2020 to 24. And these have been based on a review of all the evidence that we have and a range of engagement that we undertook over the last year to 18 months before it was produced. This involved a lot of people, including people that use our services, our staff, the wider public, but also yourselves. And what we've also provided is a summary of all that evidence as an appendix. So I think really that the main bulk of the information is there. The new outcomes are summarised in the section 4.3, and it sets out the kind of key action areas we would propose to focus in relation to those outcomes, but bearing in mind what I said previously, that we do need to refocus and recast in line with the changes to how our services need to be delivered going forward. So I think that's probably what I need to say.
Thank you very much indeed, Kim, for that overview. And as you say, it's important that we get this agreed today. Members, over to you. Any questions or comments for Kim?
Dennis, your chair.
Dennis?
Thank you. Obviously, on the equalities, I'm always sort of wanting to hear and to have the reassurance that we are meeting our obligations. And one of the things for me is communication and how we communicate this as well. And I probably bring it up at most meetings, Chair, but in terms of our people with a sensory impairment and maybe those who are deaf and hard of hearing, you know, it's about accessing the information in an appropriate way. For instance, if I take COVID, for instance, it took several reminders to the council, for instance, to have BSL information available. And we were well into COVID before that actually happened. And one of the things I'm looking for is not an afterthought, that we actually embrace and we ensure that information that is being provided, and if we're looking at equalities and inequalities, and one of the groups in terms of employment, for instance, is those who are deaf and hard of hearing as well. They have a very high rate of unemployment, and a lot of it is down to the inequality agenda. So I'm just looking for some assurance there that we are reaching out and we will embrace, obviously, the level of communication that is necessary. Thank you, Chair.
Kim and/or Joe, Joe, do you have any comments on that, please? Then I'll go back to Kim.
Yes, I think they're definitely something we need to give further thought to how we do that. Obviously, it's a complex area in many respects, and we also need to make sure we have the resources in place to be able to design and do the communications in a way that is suitable for BSL. So, for example, I think some of the council stuff that they did, as you pointed out, Dennis, was quite good with having signed videos of information so that people can watch it, but they can also listen. But we do need to have the resources in place to be able to develop those communications tools.
Kim?
In terms of the specific outcomes that we've identified, kind of enabling people to be able to communicate and be communicated with is a key part of that, and ensuring that people have accessible information is one of the action areas we've identified. So that is both for people that whose language is not English, is not their first language, but also for people with sensory impairment and other challenges. So absolutely, it's highlighted. I'm not saying we've got it right. We definitely need to do more, but it's definitely been identified through the process of evidence gathering, and it's in the outcomes as a focus required.
Thank you, Kim. Dennis?
Sure. Yes, thank you, Chair. Appreciate the responses, but it actually does raise concern because the response is based on resource. And I think that's one of the aspects that people will say in the deaf community, and I'll focus on them for a second. In the deaf community, that they say, well, you know, people aren't communicating with us because either they don't know how or whatever. It concerns me that we're saying we will if we can, but we might not be able to because this is based on resources. It's a particular group of people that do require communication and a specific type of communication. And I think I'm looking for a greater reassurance that it's not just down to resources. We should have that will to ensure that we do communicate with those that are not using English as their first language, for instance, and that does include people who are deaf and hard of hearing. Thank you, Chair.
Thanks, Dennis. I'm not sure that's what I picked up from what Kim said. I think it is part of the outcome. So, Kim, do you want to come back?
Whilst we do obviously have resource restrictions, we are highlighting that there is absolutely a need for us to ensure that we do have accessible resources to effectively communicate, and the support available to people that are using our services. So that is absolutely in the plan as one of our priorities. I suppose that's in the caveat that all of this depends on the total resource and it will be proportionate, but it's not to say that it won't be done because we don't have enough money. It is absolutely in the plan that we need to prioritise this and improve on where we are already.
Grateful to Kim. Thank you, Chair.
Thank you, Kim. That's I think what I took from it. But Angie, you wanted to.
I think possibly Kim's already kind of covered my point, to be honest, but more than happy to take this discussion off table to see if we can discuss it further and put anything else in place that Councillor Robertson might feel is more reassuring to look at that evidence a bit further, if that would be helpful.
But I think that's helpful, Angie, but I was assured by Kim's response, and I think it is an outcome, so it is something that we'd be working towards. But in any case, is in terms of the importance of equalities and mainstreaming that strand of work, can we approach any national bodies for additional resource in terms of funding? To make sure that we can actually take forward these actions and outcomes. I do think there's maybe a wider issue, but if there is any national funding available, then we can make some approaches around that as well. Because I think with everything else that's going on, we do have to be clear where the resource will come from. So I would suggest that we approach national bodies for additional capacity to be able to absolutely give that assurance that Councillor Robertson's seeking, but I think what Kim has said is that it is a priority. Okay, I don't see any other comments or questions for Kim. The recommendations are to consider the progress made towards meeting the public sector equality duty, noting the evidence which is included at Appendix A regarding mainstreaming and the 16 to 20 equality outcomes. We've been asked to approve the new equality outcomes for 20 to 24 and instruct that steps are taken to recast the actions and projects to achieve the new equality outcomes in light of the Health and Social Care Partnership needing to deliver services differently as a result of the COVID-19 pandemic, and report to the IJB within 6 months. Can we agree those recommendations, please?
Agreed.
Agreed. Thank you. And with the action that we'll try and seek external funding to support our goals. Okay, thank you very much indeed, Kim, and thank you for all the work that you've been doing, not just in terms of the equalities agenda, but you and your teams have been extremely proactive and inclusive within the response teams that have been across Aberdeenshire. So I think public health have really been at the forefront of the work that has been going on and will continue. I think there are new opportunities arising from the situation, and I would like just to pass on my personal thanks, but the thanks of the IJB to you for your leadership and to your teams that have worked so closely with others across Aberdeenshire. So thank you very much.
Thank you very much.
Now, colleagues, that brings us to the conclusion of the public section of the meeting, and I will confirm that that has now concluded and that the recording will now be stopped.